that the chairman of Chair is on here, forum. Chairman of Chair Forum, you are needed here. Chairman, members of the Forum of Chairs here present, all delegates here present, ladies and gentlemen, kindly allow me to stand on the existing protocol. Delta State Contributory Health Commission is a well-known name in the health industry. When it comes to health insurance financing, we have been able to push. In actual fact, we're the first agency to start full-fledged health insurance implementation. I remember Lagos State passed the law, the first to pass the law, but we passed the law and started before them. Since then, we have been #1 in the federation, and like the Dr. Igwe said earlier on, our issue is no more enrollee numbers, but how do we give them the best of care. So today I'm going to talk on innovations in health insurance, factors that make the Delta story a success one. Presented by me at this maiden National Summit of the health insurance agencies. And I want to tell the chairman here, I'm very proud of you. I'm very proud of my colleagues. This is one of the few conferences I attended and we have a full hall by the second day. Usually after the inauguration flag off by the governor, the whole thing becomes empty hall. But we have a full hall today, and I want the hall to be full as I'm delivering my speech. On the board, I hope, is the slide going on? Is the slide on? It's not yet. Is it on? It's on. I can't see the board. So which slide is there? Okay, let me start it from the very beginning. Please start from the very beginning so we can flow together. Innovations in health insurance. Delta State have well over 15 innovations in the last 3 years. I will implore you to visit our booth. You will see all the innovations. I can't discuss them here, but 15 different innovations that have kept us flying and becoming #1. Next slide, please. The paper is presented by me. Next slide, at this maiden National Summit. Secretary, sir, Ma, are we flowing together? Yeah, but they must flow with me. Okay. Me, the guest speaker. At the time, the guest speaker was the chairman of the governing board of the University of Calabar Teaching Hospital, former chairman of the Delta State Contributory Health Commission for 8 years, before becoming the DG of the same commission. Next slide shows the educational level of the speaker, strategic appointment over the years, It is both an honor and indeed a personal privilege to be here to deliver this paper to you. I salute the CEOs for what they have done, and I appreciate you. And I think our second summit will be much more better than this. Introduction. Reducing fraud in social health insurance. Worldwide, fraud remains one of the greatest threats to sustainability, efficiency, and credibility of social health insurance programs, particularly in low and medium income countries where Nigeria belongs. Worldwide, fraud is estimated to be about 10% of claims, but I can tell you in data we realize it's well over 20%. Now, before I go that, I would like to talk about the developmental stage of social health insurance. There are phases you must follow. Social health insurance system typically evolve through series of developmental stages. Which stage are you? Which phase are you? Phase 1 talk of conceptualization and policy formulation. This is where we started from. Stage 2 is pilot and initial implementation phase. Most of us have gone beyond that. Phase 3 is expansion and scale-up phase. Extension of coverage to additional population groups, including informal sector, vet workers, and so on. Increase in accreditation healthcare providers, strengthening of information technology, enrollment, and payment system, enhanced public awareness and enrollment campaigns. Most of us are at these stages. Then phase 4, consolidation and institutionalization of and strengthening phase. Here, improvement of governance, accountability, and regulatory mechanisms. Strengthening quality assurance and anti-fraud system. Enhancement of provider payment mechanisms and financial sustainability. Then integration of digital technologies and data analytics. Delta is at this stage. Delta is at this stage where you must fight anti-fraud. You must fight fraud. You must fight it with technology. And you must be able to analyze. We have even gone to what we call predictive analysis. In stage 5, universal coverage maturity phase. Here you have near universal or universal population coverage, comprehensive benefit packages, strong financial protection against catastrophic health expenditure, continuous quality improvement, efficiency, optimization, and equity monitoring. Then sustainable financing supported by contributions, government subsidies, and other revenue sources. This is the final stage. Like I said, there are 5 phases. Every health insurance agency must check these stages and determine where you are and what you need to do to move to the next stage. Like I said, Delta is on that stage. Now, that Delta is, number 1, is not disputed. National Health Insurance put it very clearly here. On this graph, it's on the slide, you will see that Delta is 3.3 million plus. Lagos State is second, and other states follow. If you come, that is in rolling numbers. If you come to population coverage, Delta State is still very high there, 54%, followed by FCT and other states. So that Delta is no more bothered about numbers. We are now bothered about fraud and how do we control it. How did Delta State saved 2.1 billion in public health funds in 1 year? That's what I'm going to tell you the story, and you might have to apply it. Nigeria, the continent's largest population, mirrors these challenges of fraud. The situation is a great threat to the sustainability, efficiency, and credibility of social health insurance across this country. Innovation in health insurance are urgently needed to address this structural weakness among others. In Nigeria, national agencies are increasingly pioneering approaches to deal with this monster. Delta State stands out as one of the most successful examples, having developed a contributory health insurance model that's inclusive, technologically driven, and anchored on strong governance. As of this moment I'm speaking here, a few minutes ago, Delta enrollees is 2,913,898. You can verify this by going to our booth, because our booth is live. Anywhere we are in this world, any registered person hit our dashboard with this facial captured. This paper presents the Delta State Contributory Health Commission experience, highlighting its innovation in fraud control. It aligns one of the strategies that have enabled Delta State to increase health insurance coverage to 54%. Because of the huge amount of bill we receive and pay every month, fraud is now one of our big threats. Thus, the urgent need to innovate to contain this monster. Now, the problem we need to solve. Before 2015, fraud was greatly draining our resources, and we were finding out after the money had been paid to the providers. For example, we have 9,448 duplicates, both bills and human, in 2023. The bills, average bill that we received from 2023, 24, 25 was 3.5 billion. And then we can only discover this fraud after they have been committed and paid for. 5 fraud vectors targeted our scheme: identity fraud, duplicate enrollment, ghost billing, prescription manipulation, and inflated claims. Traditional retrospective audits meant we only knew after payment had been made. We sent a team to investigate 14 hospitals, and within 3 months they have defrauded the system worth over 14 million, and we have paid them. And so our innovation to scot this problem: the dual control fraud prevention framework. We built Nigeria's first integrated fraud prevention system, attacking fraud at both ends of the service chain simultaneously. At layer 1, facial biometric verification. The person must have been registered with facial biometric, and you can't duplicate somebody's face. The face of my chairman is his face of my chairman. And so, close the identity gap, which is a major fraud point. It verifies who is being served before the service is rendered, not after the service is rendered. 842,601 verifications in 515 healthcare facilities was done in 2025 alone. And then we went further to go to layer 2, service quality monitors. This closes the service delivery gap, verifies what was actually delivered at this point of care. 300 SQMs were trained and placed in hospital pharmacies. Their duty is to verify the precision given and how much of the drug was refilled, and if there is a short change, both a scanned copy of that is sent to the commission real time, and there is a doctor verifying this precision and can even call the hospital immediately to intervene. You can go to our booth, you will see how it works. Neither the beneficiary nor the provider alone can determine the validity of a service encounter. It is designed to make sure that there's no argument at the end of the day. Now, layer 1, facial biometric verification. At enrollment, establishes unique biometric identity per beneficiary, prevent duplicate registration, eliminates gross beneficiaries, strengthens enrollment data integrity. And then at point of care, verified identity before services is rendered, prevent impersonation and card sharing, generate time-stamped encounter records. Time-stamped. You can't argument about the time. The time is there in the information sent to us. Strengthening claim verification trail. 842,000 biometrics done in 415 facilities out of 533 facilities. That's 78% coverage. Layer 2, service quality monitor. This is very important. 300 trained SQMs stationed inside the accredited facilities, eye on every prescription, real-time data to headquarters for monitoring. It ensures enrollees are attended to seamlessly at point of care, confirm all services billed were actually given, create an independent audit trail separate from provider records, verify medicines dispensed that match physician prescription, create dispensing information electronically in real time, and this is transmit all encounter data directly to the commission headquarters in real time. 300 SQM deployed, 250 facilities covered, 219,000 prescriptions were transmitted to headquarters for review. Now, evidence, billing trajectory between 2023 and 2026. After launching the dual control in 2025, hospital billing dropped 38.9% in a single year, saving. In 2024, we got, so in a way, what I'm trying to say here is average. 2023, 2024, and 2025. So if you look at the graph, you see 3.5 billion bills sent. We vetted them to 2.9, and then we saved 0.5. In 2023, that's old. In 2024, 3.45 billion sent, 2.9 billion vetted to for payment, and saved 0.47 billion. But look at 2025. 2.14 billion cents. See that the bill have dropped from 3.5 to 2.1. So there's a big major savings there. Then the bill were vetted using the SQM results. We put the SQM result again by the side of the bill sent from the hospitals. And you will now find magic. Someone who treated malaria, he gave only paracetamol. And yet you want me to pay for full malaria treatment. You treat sepsis, you gave only 1 or 2 drugs, and you wrote 5 drugs in the prescription. And then you want me to pay for full. So we did not. And that saved again another 0.7 billion. So if you add the money saved by the bill dropping and the money saved by SQM prescription being used to compare the real bill sent, we have saved 2.12 billion in just 1 year. And let me tell you, we invested how much in this business? We invested 256 million. Salary of the SQMs, digital equipment they use, and other things. And the savings is 2.1 billion. A savings that is huge, meaning a ratio of investment to return on investment is 1 to 9. In other words, you should not be afraid to invest in this concept because you will recover the money from the system. This table explains it. The number that matters explains what I'm saying. Therefore, why this innovation is unique. A global first. We dare say it's a global first because we find out that the second layer of care of fraud control in other world, a part of the world, is usually AI. But we use human this time around. And no other place we have found out in the world that is using that. To the best of our knowledge, no published health system globally has combined facial biometric beneficiary verification with independent real-time service quality monitors who validate drug dispensing and transmit encounter data directly to the insurer within a public health insurance system in the world. Please, if you have evidence, let us know. So, biometric authentication, service validation, drug dispensing validation, independent provider oversight, real-time claim integrity. This is the uniqueness of the Delta model. Now, yes, thank you very much. In conclusion, 5 lessons every state health insurance agency in Nigeria must hear. 1, prevention here beats detection. Don't wait to detect, prevent. Number 2, dual control outperform one single layer control. 3, real-time data drives accountability. You must have data in real time. Number 4, scale is achievable. We did this in total of 533 and deploying it in 415 facilities, and it worked in 1 year. Finally, number 5, return on investment is undeniable. If you invest 1 naira, you will get 9 naira back. So it is something that you can take to your board and to your governor, properly presented, it will allow you to present. I would therefore say, in concluding, I've been told I have 5 minutes, I'm going to jump some of my slides. I will say the Delta State model needs to be discussed at the SHIA level in our next meeting and see how we can use it to protect our organizations. Because funding is scarce, it is not something you are allowed to waste, and therefore, please, gentlemen, I want to thank you. I'm grateful for this opportunity. God bless you all. God bless Delta State. God bless SHIA, and God bless the Federal Republic of Nigeria. Thank you very much.
Another round of applause, because we know that I know they carry last. So he adhered to the time stipulated.
Thank you very much.
Thank you for the good job.
Thank you.
Yes. We're moving on, very distinguished ladies and gentlemen. And I know I will take 3 questions. I recognize you, sir. 3 questions. Seems you are the only one. Please come up. Okay, 2. 2. Where's 3? That's it. There's no woman. I need 4, and I need a woman. Thank you. Right. Can we have the microphone? Please make it as short as possible. Please, our ushers should come up here. Quickly.
No, thank you. Thank you very much. Abubakar Yorima from Chai again. Just to congratulate Delta for this remarkable achievement. We will go to your booth and learn more during break. But I have 1 question and a comment. The question is really about service quality. Did you look into how the dual control mechanism has had any potential effect in terms of unintended consequences on patient care? For example, health facilities doing quality skimping on the delivering services because they don't want to spend so much because of the controls that you put in place. It would be really interesting to check if you have any insight there. The second, which is more of a comment, is what you've achieved is remarkable, and like I said, we'll go and learn more. But Additional comment that you might also want to consider as you think of going forward, what next steps might look like, is maybe diagnostic related groups as a strategic purchasing mechanism, right? Since you've already have achieved that level of maturity in your enrollment and your claims management system, would you want to consider a rather more technical and more sophisticated what do you call it, provider payment mechanism, which is the diagnostic DRG, right, where you can group health facilities based on yardstick competition? But I would really love if you have any insights on the first point around any unintended consequences.
Please hold the microphone first. I want you to just ask the question clear. One word or 2 words, not 2 long stories. Number 1, what do you want me to do?
Have you found, did you understand any unintended consequences in terms of facilities not delivering the level of quality services because of the fraud-related interventions that you put in place? Number 1. 2 is that, are you considering diagnostic-related group, which is DRG, as a mechanism for provider payment, which is the next step for you? But the second is more of a comment. Happy to discuss it later.
All right. Thank you very much, sir, for. It's actually an impressive coverage. 2-point-something million. It's a great thing that I think every share must learn. I am Dr. Yakubu Kennedy, the Director of Formal Sector. I'm standing in for my Executive Secretary. My question is regarding to the capitation you pay. I was able to storm into your booth and then discovered that you pay like 570 as capitation. My question is, was it actually determined? And if it's so, please, what would you advise? Because currently in our own climb, we are having challenges already with providers with a capitation that is even beyond this. I know your numbers are more, but if this thing should be sustainable, looking at the economics of it, well, marginal cost is less than the marginal benefit, I think we might not be able to sustain it for long. So I don't know. I want to ask if the 570 you're currently paying is actually determined, or it's something that is done out of a political will to support a lot of enrollment. Thank you.
Can you please write your questions for those of us who would need to ask? We're having a problem here. Or what you can do is, if you can line up quickly and come to the podium. Thank you. It's important for him to hear the questions so he can react to it. No, please. Please, can you come up? Thank you. And the next person after him should please wait on line here. Yes, ma'am.
Thank you very much, moderator. Thank you, Dr. Oloriogun. Can you hear me? Yeah. I think I must once again appreciate the organizer of this event. Sincerely yours, this event is the one that I see hope for Nigeria. And now at this level, I've attended several meetings, several gatherings like this in X sector. As a former national chairman of ACPN, this is the first time I will hear people talking about fraud control prevention in X sector. The very first time. Because one issue we've been fighting, even as a pharmacist group, I'm sorry, I'm not talking now as a government official. One issue we'll be fighting, we'll be talking about with insurance in Nigeria is the issue of fraud. And that is because the way it's been implemented. The SSHIAs, which has been there for long, it is because of fraud that has not made it to be this successful. Happy to hear what you guys are doing in Delta. But I also want to say that when we talk about health coverage, universal health coverage, we talk about, it's not about getting services, we also talk about getting quality services. Quality is very important. We are here together as health providers, doctor, physician, pharmacists, nurses, everybody here in the house. You talk about the services of pharmacy. Okay, the pharmacy, how do you, because universal capitation, global capitation, to use the correct word, global capitation is one area where fraud in health insurance in Nigeria has been established, universal coverage. So, what are you doing? If you must prevent fraud in health insurance, you must critically look at the issue of global capitation, breaking it down. Thank you very much. I'm sorry.
Thank you so much again. I remain Dr. Kennedy Yakubu from Adamawa State. My question is regarding to the capitation, sir, that you pay as an agency. I learned from your book that you pay $570 per head for capitation. I wanted to ask if that was actually determined or is just a political will to just support the program. And if it is, because currently we have faced a lot of growing demand from providers, from the supply side, to see how capitations can go up to beat up with their own costs. So, and from the economics of it, if marginal cost is not equal to or is less than the benefit from the supply side, definitely the system will not be sustainable. So would you advise other shares to look at the mode of reducing, or is that what was determined actuarially for you to be paying? And we really want to learn from that, but otherwise very impressive coverage. We look forward to also having that number in our state. Thank you.
All right, good afternoon, everybody. My name is Emanuela Sopo from Benin State Health Insurance Agency. Good afternoon, sir. Well done for your presentation. I don't know who I would have directed this question to, but this is the question, sir. Benin State is yet to be on the formal sector. We are still running the BSCPF program, and one of your presenters talked about doctors being in the primary healthcare center offering consultation services, and then their payment coming from the capitation that we normally pay. How is this sustainable? That's my question. Thank you very much.
Thank you for the innovation of bringing them on stage. The first question was on quality and global capitation. Now, the second question is also capitation. But at the pharmacy level, the SQM deployed to the health facilities ensure have increased our quality service tremendously. We realize at a stage, some hospitals don't even attend to our enrollees. They go there and they shortchange them, they bypass them. But since we did two things, I also want to announce that we put health insurance unit in major hospitals. Health insurance unit in major hospitals where our enrollees go to first. There is a building allocated, dedicated to health insurance in major hospitals in Delta State. We call them zonal hospitals, where the majority of enrollees attend. And this place is manned by a doctor, minimum a doctor, a nurse, and other staff. And so when you arrive with the signboard of this health insurance on that building, the enrollee moves straight to that center rather than joining the queue of the crowd. Secondly, there is a doctor dedicated to caring for consulting the patients, the enrollees. And that have increased. Quality is not about only drugs. It's about the totality of care of the enrollee, the reception doctor gave to him, the attention that you rendered before you talk of the drug. And so a lot of our patients are now happier that they get to the hospital and they are treated like human beings. And that is, quality has increased tremendously because we have our SQM right there processing the attendance. And then in terms of the pharmacy, in Delta we took a lot of pain. We sat down with the pharmacists, we sat down with the operator of the hospitals and determined the price. Majority of payment in Delta is bundle payment. Malaria, for example, we have determined how much do you take in treating simple, straightforward malaria. For example, calculate all the drug is 2,000, 3,000. We now add 50% to that. And so we have agreed on how much you will make on top of that. And at the end of the month, when you send your bill, we pay you that amount of money. And so we don't use what they call global capitation. For those we give capitation to, I will tell you we were able to use the facial encounter to determine the percentage attendance of capitated patients. It's right on our screen, you can check it. We find out that majority is below 10%. So a hospital is having 10,000 enrollees and only 10% attended hospitals. And the capitation on them we are paid in advance is 500 for government hospitals and 520 for private hospitals. And so use 500 to multiply the only few that you have attended, the 10% or 4% or 5%. You are making good marginal profit. And so there is no reason for you to shortchange the person. On the other hand, we don't pay 570 for our state enrollees. 570 is by BACPF, and that is determined at the central level. We pay 500 capitation to government hospitals, and we pay 520 to private hospitals. It was actually determined. I know federal, the NSHIA is paying 1,000 plus now. They have money. But no state health insurance is paying beyond 500 to 600. And that's what we can, and it's also dependent on your benefit package. Capitation payment depends on benefit package. And so for that question is actually determined, and there's a profit margin in it. We have determined that, value percentage approval, percentage profit margin very well with the hospitals. As to Kebi, I think your question, we'll sit down and look at it and discuss it later. Thank you.
Thank you very much, sir. Please, can we appreciate him again? Thank you. Thank you. Yes. Yes. At this point, I'd also like you to once again appreciate Delta State for the milestone that has been recorded. We're moving on very, very quickly. I would, at this moment, I'm happy that the two of them are sitting together. We did say that a foundation was laid, and that foundation is what we're all witnessing here today with this maiden edition of this summit. Those who laid the foundation are also present. I'm sure that these are exciting moments for them. I'd like to invite here quickly Dr. Guinea and Dr. Onyekoro. I want both of you please to come, because I want us to be able to put health insurance history into true perspective. And these two gentlemen who pioneered what we are witnessing here today, the cohesion, the unity of purpose, which they both served for Nigeria, for health insurance at the subnational level to emerge is why I have invited both of them. Dr. John Onyekoro was the life wire of the Secretariat, and of course, Dr. Guinea was the first chair of this forum. So, ladies and gentlemen, can we please give these two giants a round of applause? And I want it to be very, very loud. Yes, you didn't see this coming. That's not loud enough for people who laid foundation, who made it work. You recall yesterday I invited Dr. Dogo to give us a reflection, the true evolution of health finance in Nigeria. So I want to thank both of you, and we are going to hear both of them speak today. So, Dr. John, thank you. I'll ask you please to take your seat. At the appropriate time, I will call you in. But now we're going to listen to Dr. Ogini to speak to us. Thank you, sir.
Thank you. I don't know. I'm quite humbled. I didn't see this one coming. Thank you very much, Auntie. And standing on the existing protocols, I want to express thanks to Almighty God, because He's the one that makes things possible. When we started, we only envisioned a great future, but the possibility is actually of God. And sitting down there, hearing and seeing things that I've been seeing and hearing, I am quite elated. And I thank you once again for these kind words that you have spoken. Today, my assignment is straight to talk about the imperative of, let me just get my slides on now. Yes? How many minutes? 30 minutes. Just, I'll walk through it. Yeah. So, I hope it's been projected. Enforcement of mandatory health insurance at the subnational level, an imperative for universal health coverage. I'll take us through some snippets on the background and the contents of this topic I'm going to be discussing. I'll talk about the legal and policy frameworks that enabled enforcement of health insurance at both national and state level. I'll talk about the roles of state health insurance enforcement. I'll talk about the current status of state health insurance schemes. I'll talk to us a bit about the rationale for mandatory health insurance, the enforcement mechanisms. We'll discuss opportunities and benefits of enforcement. We'll look into the challenges and the risks. We'll look at a case study of a place or a state where enforcement is working and producing results. Then we'll go to my recommendations and my conclusions. So I wouldn't like to bore us, but we know that out-of-pocket expenditure is responsible for about 70% of our total expenditure, and that high out-of-pocket expenditure impoverishes households. We know also that the health insurance has been found to be a very key strategy for achieving universal health coverage, and that the National Health Insurance Authority Act 2022 made health insurance mandatory for all Nigerians. This is where we are drawing our strength from. And that the states are expected to domesticate and implement the provisions through state social health insurance agencies. And that's why we're here. The biggest assignment that we have as states towards achieving universal health coverage is for us to ensure that we domesticate that law that makes it mandatory for everyone in Nigeria, even if you are a resident or a visitor, to be enrolled in health insurance. So what is universal health coverage? You have said all of that, so I'm not going to bore us with it. We know it's making sure that everybody, everywhere, they get the service that they need of the good quality to be effective and without financial embarrassment at a cost that doesn't impoverish them. Now, how does health insurance support this? Health insurance supports this by pulling the health risks together, by increasing access to care, reducing out-of-pocket spending, and protecting the vulnerable populations. Now, to enabling, legal and policy framework, we have the National Health Act Authority Act of 2022. We struggled a lot to get this act to come out because initially it wasn't like this. And of course, since if there is no act that enforces or that mandates health insurance, we will continue to go around in circles and we never get to, the destination, which is universal health coverage. So we have the National Health Insurance Authority Act, and the key provisions are that health insurance is compulsory for every Nigeria and every legal resident in Nigeria. And as states are encouraged to establish their own SSHIAs, vulnerable groups should be covered through equity funds. Now the journey, those of you who are with us at the beginning, the CEOs, you remember when they first brought the benefit package for basic care provision fund, and they said that you would have, it's to cover all Nigerians. You remember the narrative then was that, basic care provision for all Nigerians. And we started telling them that, look, you cannot make it for all Nigerians the way it is. We must prioritize. And that's how the narrative changed to becoming for the vulnerable. We kept harping it until it sank. And we were actually instrumental to ensuring that that was, the narrative that was carried on, that basic care provision funds should be first for the vulnerable groups. So we have it as equity funds. And the National Health Insurance Authority provides oversight and technical support. Now, where the states need to do more is that we know that the state governments have laws. Many of the state governments have laws. But even as I speak to you, it is not all the laws of the state SSHIAs that makes it mandatory for everyone to come on board. So I believe that one of the biggest assignments that those states will have to do when they get back home is take these, documents, develop a policy brief, give to your principal and let them know, and engage your legislators that if your law doesn't make health insurance mandatory, you will continue to run about in circles. Now, what are the functions of the SSHIAs? We know them all, but I'll just remind us. We enroll residents, we are credit providers, we manage funds. We can use that also. We can even use third-party administrators to do that, and we can do it ourselves if we have the capacity. And then we purchase healthcare services, and that purchase must be very strategic. That's one of the key critical success factors for health insurance, strategic health purchase. If you are not purchasing strategically, then you are losing money. And then, of course, we monitor the quality of service that's delivered, and then we enforce compliance. Why do we need enforcement? We have many challenges in the system. And these challenges range from low insurance coverage to public, poor public awareness. We have wrong perceptions. For many of us, based on religions, we have wrong perceptions. There are informal sector exclusion. We have high out-of-pocket expenditure and limited risk pooling. These are challenges. And we know that without enforcement, voluntary enrollment will remain very low because only those who are sick will come. And so adverse selection will increase. And the same way, for financial sustainability becomes very difficult, if not impossible. Therefore, what are the objectives of our enforcement? We are enforcing because we want to expand population coverage towards achieving universal health coverage. We are enforcing because we want to increase financial protection, improve access to health care, strengthen the risk pooling, where the sick will be subsidized by the strong, the weak will be subsidized for the strong, the young, subsidized for the old, and then the rich will subsidize for the poor. Now, we also want to ensure that we achieve the state-level universal health targets and to reduce healthcare inequalities. Now, what are the strategies for subnational enforcement? Looking at it from the administrative enforcement perspective, from administration, what we need is to ensure that there's mandatory enrollment of all civil servants. One of the things that gave a push to our own scheme was, the first thing I achieved was I got my government to release about $500 million, for equity funds, even before basic care provision fund came at all. And then I got my government also working through the labor to, onboard all the civil servants. So within 2 years, we actually, shot high because everything was in place for us to achieve success. So mandatory enrollment for civil servants, then mandatory enrollment for all pensioners, and then the payroll deductions were applicable. Once you are able to achieve this, then we are making progress. Then the regulatory enforcement will include compliance requirements for employers, provider accreditation requirements, licensing linked compliance measures. What we are trying to say here is that now many of us drive our cars and every year we renew our license. Now if you link the renewal of license to having a certificate that you are enrolled in health insurance, very soon the number will increase because you can't register your car without it. You cannot even register your company without it. You cannot put your children in schools without it. As you do that, we will see that the number will increase. And that brings me to the service-based enforcement. When it becomes a requirement for insurance evidence before you can access any selected government service, you become, all the states will experience an escalation in the number of enrollments if we use these various strategies for enforcement. Now, what are the possible enforcement instruments? You can require proof of health insurance for government employment. So if you are seeking government employment, you must be, enrolled before you can get that. And so if someone knows he's going to get a government job, he might, seek support from members of his family to get enrolled into the health insurance scheme. And then, of course, business registration renewals, public procurement processes, occupational licensing, school enrollment programs, social intervention programs. If government is doing some empowerment schemes, those who do not have health insurance, evidence of health insurance registrations will be excluded. So that becomes a kind of, indirect incentives for everyone to come on board. So these are possible enforcement instruments towards increasing the enrollment in health insurance. And then such measures, of course, must remain equitable and legally supported. Now we want to look at a case of a state, one of our states, that as we saw Delta has done a lot and they have achieved success in terms of the total number of enrollees that they have. But there's a particular state that has also done well in the area of enforcement, and that enforcement has helped in increasing the number of people that are covered under the health insurance scheme. And that's Lagos State. Lagos State is emerged as the leading state in operationalizing mandatory health insurance. And what were the actions that were taken? This includes the executive order making health insurance compulsory and the establishment of dedicated enforcement structures with the phased implementation beginning with the government institutions and integration of compliance monitoring within the ministries, departments, and agencies of government. Now we can see there how they started. Phase by phase, Lagos enforcement model is projected there. And we see at phase 1, it was the MDAs with the public servants. Then at phase 2, they went to local government and formal private sector. And the third phase is the informal sector. Even the formal private sector is a hard nut to crack in some areas, except we have very strong, structures to enforce their compliance. And so we know one of the things we need to do here, for those who have already achieved the MDAs and the private sector, public servants, we need to go towards ensuring that local governments, and now that we have local governments, autonomy, we know that we have to engage local government directly. Otherwise, you might not get anything from them. And there is a huge population of people that work at the local government level. And then, of course, the third one is the informal sector. We know the informal sector consists of about 80% of the Nigerian population. So the more we're able to bring on board the informal sector, the more we are moving towards achieving universal health coverage. And the measures that are, to be taken include ensuring that you verify, the staff audit, verification of onboarding on health insurance during staff audit to ensure that everyone is onboarded. And then we talk about the compliance monitoring. Our systems must be strong to monitor compliance. So when we put down the rules, if we are not monitoring our compliance, people will break the rules without any consequence. And then we must embark on extensive advocacy and public sensitization efforts. Now, what are the benefits of effective enforcement? For the citizens, it is improved access to healthcare. It is reduced catastrophic spending. It also results in better health outcomes. And I must also add that it brings better productivity, because once you are covered and you are not sick frequently, you can engage in productive activity and then your lot gets better. But for states, we have expanded revenue pool. The more people are on board, the more the pool of revenue for you to be able to drive your scheme. And then, of course, that makes it more sustainable. It makes your health financing more sustainable. And then you have a better health system performance, because when you perform, when your performance is based on the percentage or the proportion of population that's covered. When you are covering this, that means you can report that, oh, Delta State is saying 54% today, and Lagos State is talking about how many percent. So it improves your performance when you have many people onboarded. And then for service providers, it increases service utilization. It improves predictable payment systems, and of course, infrastructural improvement and expansion. So it's a win-win situation if we have enforced health insurance for everyone. Now, what are the challenges that we are going to face in trying to implement enforcement? The first is financial challenges. We have poverty. Of course, poverty is prevalent. And as a result of that, both individuals and government complain about not having enough money. So that's going to be one of the biggest challenges that we're going to face. But with the will, if we have the will, we can always achieve, we can overcome that, challenge. And of course, affordability issues. A lot of people will say they are not affordable. But I tell you, if we know our people very well, there are many things that you would think is not affordable. But when the people have the will for it, particularly those of us in southwestern Nigeria, when it is a matter of ashoebi, you will see somebody who you think cannot afford a 5,000 naira fabric, he will buy 30,000 naira ashoebi. So, it's a matter of giving the right communication, giving the right content, and you will get, this overcome as you present to them the benefits of enrollment. Now, we have political challenges as well, which include policy discontinuity and leadership challenges. I think in one of the states, as at the time the shares were 4 years old, that state already had 3 different, leaders, 3 different, CEO. And of course, there was no continuity. Of course, the state is still struggling. I believe that by the grace of God, they will have learned from their lessons, and they will allow, the leaders to work for some time and consolidate on whatever has been built. Now, we have institutional challenges as well, where we have weak administrative capacity and limited enrollment infrastructure. Many of the states, now I hear that some states they are averse to engaging third-party administrators. Yeah, third-party administrators might have their own flaws, but if you do not engage third-party administrators and you don't have the capacity, either in terms of infrastructure, equipment, or personnel, to drive your scheme, if you avoid that, your scheme is not likely going to go any far. And then the next one is the social challenges, where we have the issue of trust and poor awareness. And then we have cultural resistance. Now, we must be very careful as SSHIAs, particularly as the CEOs. Once we lose the confidence and the trust of the citizens, regaining it becomes very, very difficult. And so that's why we have the onus to ensure that we manage our schemes properly, so that the people's trust can grow. Because once they lose confidence in us, it becomes a very big problem to get back. Now, what are the challenges? The informal sector itself is a very big challenge. It's a special challenge. And what are those things that constitute the challenge? There are irregular incomes, difficulty in identifying beneficiaries, weak contribution, collection systems, and they constitute 80% or more of our workforce. What are the solutions? We can engage on community-based enrollment, where each, artisan group, each worker group, each cooperative societies can, do their enrollment. We meet them one by one so that they can enroll and, fast-track the onboarding of their members into the health insurance scheme. There can be also flexible premium payments, like we did in Osun State. Sometimes we make sure that, for those groups, artisan groups, we had some flexible payment mechanisms. They could pay like twice, for the premium, and that made it easy for some of them to come on board. And then, of course, we must have a very sound digital payment platform in order to enhance our efficiency and to reduce the issue of fraud. Cooperatives and association-based enrollment I've talked about. Now, what are the critical success factors? Political commitment is number one. I remember how we started. The Nigerian Governors Forum had this, this chart that they used to bring to compare how the states were doing. I remember my governor was at the meeting of Nigerian Governors Forum, and while he just came out of the meeting, when he saw the chart, he said, why do we have red? He just saw red in Osun State, and he called me and said, why do we have red here? I said, Your Excellency, we have red because we don't have a board, we don't have capitation, we don't have equity. And by the time he came, within 2 months, he put in place the board, he released equity, and before you knew it, we moved forward. So political commitment is one of the very important, critical success factors for state health insurance agencies. And then, of course, legislative backing. Even if your governor is so willing, if he doesn't have the cooperation of the legislative arm, it might be difficult for them to be able to enact laws that will make it mandatory for people. And then, of course, sustainable financing is another critical factor. The state equity funds and budgetary allocations must come as and when due, and then you'll be able to do very well. If you don't have very good digital systems, your scheme cannot fly, because the data we're talking about is huge. And so you must have a very functional and effective digital system for you to be able to drive your enrollment databases and to verify your numbers. Then, very importantly, we have stakeholder engagement as critical success factors. You're on board the traditional rulers, the religious leaders, professional associations and labor unions. When you bring them together and you have their confidence, you are home and dry. When my governor released the first memo or the first circular asking all state workers to come on board, labor union wrote back to the governor and said, never. We are never going to be on board, come on board this health insurance, because National Housing Fund did not pay us. The contributory pension scheme didn't pay us. We are not going to, in any guise, give a kobo for anything you call, health insurance. Then I had to call a meeting of all the labor unions, and then I discussed with them. I told them based on the relationship that we have had and who they know me to be, that they should just give me 6 months, and let's work this. If within 6 months we don't achieve the results, then they can, reverse. And immediately they wrote to the governor that now they can start the deductions. That was how we started having success in, our scheme. So it's very important for you to engage the stakeholders as you go towards enforcement of mandatory health insurance at your level. So what are my recommendations? The recommendations to state government is that they should fully domesticate the National Health Insurance Authority Act provisions. They should strengthen the state social health insurance agencies, adopt phased enforcement, like I've just shown, beginning from the MDAs, and then we get to the, the public servants, and then we move from there, local government, and we can get to the private sector, and then the informal sector. They need to also expand public awareness campaigns. This can be going on regularly on radio, on all social media platforms. We need to do that. Thank you. 5 minutes more. So we expand public awareness campaigns. We need to also protect vulnerable populations through subsidies. And that's where the state governments, will to bring the equity funds comes in. Once they do that, shares will move. And then we need to deploy digital compliance systems. We have said that. To integrate health insurance into government transactions. To see it not just as an expenditure, but as an investment. If we bring the investment case for health insurance, state governors will take it on, and then we're going to be able to move faster. Now, for the NHIA, the recommendation is that they should provide technical assistance. They should standardize implementation frameworks, monitor state performance, and support cross-state learning. When we came on board, we had some challenge with NHIS. Initially, they thought we were coming to compete, but later we began to co-create everything that has moved the insurance ecosystem forward in Nigeria. And so that should also be continued. And so what are the key takeaways from this presentation? The key takeaways from this presentation are that mandatory health insurance is no longer merely a policy aspiration, but it has become a legal requirement under the NHI Act, and successful enforcement at subnational levels will depend on these factors. 1, a strong political leadership. 2, effective legislation. 3, sustainable financing. 4, robust institutional capacity. 5, citizens' trust and engagement. And I'll conclude by saying that achieving universal health coverage in Nigeria will ultimately be won or lost at the state level. In conclusion, mandatory health insurance offers Nigeria a pathway towards universal health coverage. States are central to implementation and enforcement. Lagos State provides an emerging model for other states in the area of enforcement, and enforcement should prioritize compliance, inclusion, financial protection rather than punishment. Finally, strong state-level implementation can significantly reduce healthcare-related poverty and improve population health outcomes for economic growth and prosperity of our nation. I thank you very much for listening.
Thank you very much. Thank you very much, Dr. Adeni Ogini, the pioneer chairman of the SSHIA. Please let's appreciate him with a big round of applause. Thank you so very much, sir. Financial sustainability can only be achieved if there is political will on the part of government. Thank you so very much, sir. We appreciate you. Distinguished guests, ladies and gentlemen, now we are moving into the panel session. Panel session number 3, custodian of care, strengthening primary health care quality through local ownership and accountability. And the moderator of this very important session is no other person than Chief Mrs. Moji Makonjola. Please let's put our hands together for her. Thank you very much. Please, if you have any questions or contributions concerning the lecture just delivered by Dr. Ogini, just reserve it until after the panel session. Thank you very much.
Thank you very much, Dilly. Good afternoon, everyone, again. Yes, we are going to, this will be like a fireside discussion. And quickly, I'd like to bring on the panelists. I'd like to bring on the chairman, Forum of CEOs of SPHCDAs, Dr. Kabir Mustafa. Yes. Huh? Oh, no, okay, please come on. Thank you. I also have Dr. Kabir Mustafa. Please, sir, I will read their profiles as soon as they are seated. I'd like to also invite Dr. John Oyekoro, who is the dynamic foundational secretary. I'd like to bring on my daughter, ES of FCT, Dr. Belgore. I'm now going to bring on from the traditional institution, a kingmaker, a banker, because once you're a banker for life. Please welcome with me His Royal Highness Alhaji Sada Mohammed Sada from the Katsina Emirate Council. I want that applause to be very loud because we need them. Thank you. Thank you very much. We are looking at a very important area of implementation. We can do all the grammar here, but we need to get back and get real. and get things done. The experts that are here as panelists have their own ecosystem, which they will be speaking to. And having listened to Dr. Ogini, I think it's important that we reflect back on his contribution, which is very germane to this discussion. I'll first of all go to the father in the house, not the royal father. When I say father, I mean father in the sense of public health, father in the sense of health financing. Dr. Kabir Mustafa, yes, who is still currently a health consultant and director of Matrix Health Analytic Consultants here in Abuja. He's been core member Nigeria Technical Advisory Group on Immunization, essentially member Ministerial Implementation and Monitoring Committee on Medical Simulation under TED Fund. He has also been Northwest Zonal Coordinator of CWINS, working on measles and malaria vaccine advocacy. I can read about 10 pages of what he has done and is continued to do. Having served as the National Program on Immunization, NPI, as an assistant director, and of course, attended several short courses, but more than anything else, has shown some measure of resilience that we really can turn around the tide in the health sector. Sir, I'd like to come to you first. We've listened to Dr. Ogini. He has... Okay. Who? Dr. Abba? Okay. Sorry, can I please invite Dr. Abba Saleh? Where is he? Can I call him? Dr. Abba Saleh, thank you. So we are looking at enforcement in all its ramification, and I just want you to give us, a bird's eye view of how enforcement can really come, because what we have now is implementation going forward to expand the scope of health financing in Nigeria. So let's hear your view, sir.
Yeah, thank you very much, Moji. Let me appreciate the conveners of this very important summit for giving us this opportunity to contribute to what best we can try to say as regards to how do we forge forward. Now, within the scope of enforcement and looking at what it is we want to really achieve, universal health coverage, I think we have to also emphasize on the need to understand the three dimensions that affect or push us towards achieving universal health coverage. And most importantly, what the presenter really brought out is the population. The population is the baseline. How do we get the different segments of the population to come in? And just like was rightly presented, we have to enforce it. The first enforcement we've gotten as regards the population is the mandatoriness of the law establishing the NHIA that came in 2022. So that has given us the power to push for getting more of the population into the program. Now, looking at that, it's just not sufficient. We have to look at what do we then do in terms of the service provision. The services we are giving or we are providing at the primary level are confined within the basic or the minimum basic health care package. So going forward, we'll also look at that. does that give that the population requires? There are changing dynamics in the health of the population nowadays. We are seeing non-communicable disease becoming very more. So in the initial thinking, what we had was just the basics. So as we move forward, we have to look, how do we expand the cover? As we are getting more of the population registered, we also have to look on how do we get the cover, or how do we bring in additional services to cater for the concerns that will be coming as regards the health of the population.
Thank you so much. I'll leave that to hang in the air, as I would call on my brother from Borno. I want to go to Borno State. Yes, because you have a lot to deal with. You're looking at insecurity as we are today, and there are a lot of hard-to-reach terrain because of that. And we're looking at enforcement, which is an imperative to actualizing health financing, particularly at the sub-national. What is it that should be put in place in terms of strategy, in terms of resilience, trust, and making this work?
Thank you very much, Auntie Moji. As for the case of Borno State, everybody knows where we are coming from. With over a decade-long insurgency, what we try to actually improve is actually on collaboration and stakeholder participation. We at the supply side, we can't do much if we at the demand side, sorry, we can't do much if the supply side is not actually, if we are not actually speaking each other. So we need each other to clap together. So what we try to do is actually to strengthen the collaboration between the supply and then the demand side. Especially our sister agency, like the Primary Healthcare Development Agency, as well as the Hospital Management Board. We make sure that we work together because so that at least to improve the trust. So what we are trying to do in our own case is to create demand in such a way that if there is actually a quality service, people will come to approach us to even be enrolled without even us campaigning or going to them for marketing purposes. So this is what we try to do as much as possible as far as Borno State is concerned. And more so, we do a lot with public sector because our private sector wasn't as obvious as it is considering maybe the other part of the country. Like in the southern part, I come to learn that there is more public sector driven facilities than what we have in the northern states, where we have over 90% of our health institutions are actually public sector. So it is actually very easy for the government to actually manage and implement and enforce strategically to ensure that the service is actually qualitative and is accessible and affordable. So that's what we do as far as we are concerned in Borno State. Thank you, ma'am.
Thank you. I'll come to Dr. Bashir. Yes. Well, at least I deliberately went to Borno before coming to you because I know that access, demand, and supply, well, they go together now, particularly at the primary health care level. As chairman, what is it, what needle should be pushed to stitch the gap, which of course we all see today at that level, to increase demand, for example, and also ensure supply and also ensure equity?
Thank you very much. I'm so delighted to be here and looking at particularly the social health insurance ecosystem in view of demand and supply of healthcare services. One, why primary healthcare matters is because it emphasizes both preventive and promotive care, low cost, reduces hospitalization, and it is anchored on effective referral mechanism. So like the gatekeeping there is very central. And it has also been documented that countries that have the best health system, resilient health system, have good investment in their primary health care system. Coming to the discussion that we are having here, in view of the demand and supply, health insurance purchases care, and the primary health care provides care. As we are scaling up coverage, particularly health insurance, in view of our economic realities and universal health coverage, we should look at it in the 3 dimensions of universal health coverage. We want to increase the number of people covered. So it is very important to note that we're around 20 million and we have a very long way to go. Secondly, we need to look at the coverage span, whether in terms of preventive, promotive, curative, rehabilitative component, and also the age groups affected that need to be covered. And lastly, we need to also look at the financial risk protection. And that is why, if you talk about the custodianship, there is a lot of work that we need to do on this journey of USC, even when we are trying to embark on an aggressive drive for universal mandatory health insurance. One is that we need to increase the voice accountability, as well as the quality of services to be provided. If we are chasing just numbers, we will get the numbers, but there will be far outcry that people are not happy with the service they receive, and they are not likely to give the needed utilization, and that expected outcome will be like a delusion to all of us. And that is why I'm happy that I'm here and I'm meeting our colleagues here, that a lot of discussions can be done at our various state levels. Even the presentations made earlier at the first session that really underscored so many best practices across the states, many states need to adopt them. And even some that are yet to be presented are also out there. And also from us in the PSC space, there are a lot of things that are also worthy of discussion, particularly at the state level. So this provides us with another very important opportunity that in our various states that we are here, 36 plus 1, we have best practices that we can adopt to help us in improving the quality of care so that clients and patients can have a respective or an acceptable patient experience when they visit these facilities. The community should have a voice in the sense that they appreciate, they are desirous of some changes or limitations therein as they may observe. And also issue of transparent reporting. So many best practices have been shown, but they are captured in so much technicalities that the person for whom the service is provided may not be aware. And these are things that we need to prioritize, and more community engagement and giving voices to our community. Lastly, I also want to say that I had a lot mentioned about enrollment, claim utilization, and so many of those issues. I think we need to go beyond that. Let's also look at issues about provider accountability, those quality issues that we need to discuss, and also issues about community engagement and accountability and performance measurement and also performance reporting. A lot of digitization are out there. I visited so many booths yesterday, and I saw so many great work being done, but it's done in a silo that meets the other arm in the service provision angle to be carried along. And ironically, most of them have that opportunity for interoperability of most of these services. So I urge all of us to give further engagement in the various platforms that we have at the respective state level so that we can strengthen quality, emphasis on purchasing quality care, not any other care. One thing is that the clients always accept a health system, not separate health institutions as the case may be.
Thank you very much. The takeaway there for me is that we have best practices that have been so outlined, and these are things that should engender, the evolution of installing and ensuring that we can improve and, of course, enforce mandatory health insurance at the sub-national level. I'm coming to FCT. I know you're new, kind of, because when you should have been the one showing us the way. But thank God you're on board now. So, how do you engage in terms, because we have urban areas and we have rural areas, combined at the Federal Capital Territory. How are you able to engender trust that will bring about enforcement? And is this, what are your experience now that you think are lessons that we can learn from what you're doing? Okay. Yes.
Okay. Thank you very much, Auntie Moji. For the Federal Capital Territory, what we have done to be able to, encourage trust from the populace and from the communities is we have structures on ground in the communities already. So we try to leverage on already existing community structures. For example, we have what we call the World Development Committees, the Village Development Committees that work hand in hand with the PHCs, the primary healthcare centers. And of course, we have at the local government level, we have people that also, liaise with these committees to work together. They have regular meetings to discuss issues around the welfare, not just even the health, not just issues that borders around health of the people, but also other issues that has to do with their welfare. So we have those structures in place. We leverage on them. We get, to dialogue with them. We get feedback from them on what their priorities are, what are the predominant or prevailing health conditions. So we're able to prioritize based on those information or feedback that we get from them to move into the communities and, provide services as at when due and when needed. FCT is very peculiar, like Auntie has said. We have, when you go into FCT, you think FCT is all, an urban area. But FCT is actually a cosmopolitan city. We have we have semi-urban areas. We have very rural areas that you even have to go, some of them through Niger State, to access some areas in, for example, Abaji Area Council. So what we do basically is we have those linkages and we work hand in hand with them to ensure that we provide services to every nook and cranny of those communities. So for example, what we did in linking, ensuring that our enrollees had NIN was that we worked with the community members. We liaised with them, we did some sensitization, and then we moved into the communities, in a phased manner, and then we're able to go into the nook and cranny, work along with them, get them sensitized, get them on board, get them informed. We work with the locally existing community structures. They believe more in their own people. They have their dialects and all of that. So they speak to them and they speak our voices, and we're able to, get their buy-in to embrace our services and access services at the PHC levels. Yes.
On the scale of 100%,
Yes.
or maybe I'm taking it too far, how has the enrollment gone? And are the people at that level or the lower level, are they have they accepted the enrollment to the health insurance?
Okay, so as at August last year, we had a total of about 37,000 enrollees, but we were mandated to ensure that all of them have NIN, and out of those 37,000, we had only 8,000 of them with NIN numbers. So what we did was to use the polio immunization campaign model to, roll out a program for the enrollment and sensitization and, NIN capturing for these people. So we're able to go, in a phased manner to enroll them, capture them with NIN, get them on board, and success rate was at the end we're able to enroll over 69,000. Our target was 70,000. So we were able to enroll over 69,000, which was about 98% coverage for the enrollments under the BHCPF services.
Okay.
Yes.
Right. I'll come to you, former secretary, and she said that they were able to enroll people under the BHCFP. Now, how sustainable is that in terms of enforcement to make this system work? And beyond that, somebody spoke to best practices. How can we transfer these best practices and not have an academic exercise like we're all listening to each other here? How do you bring that best practice to play and to ensure some measure of enforcement of mandatory health insurance?
Thank you very much. I think part of the reasons for the formation of the forum was to aggregate best practices and leverage on the collective goodwill we had to ensure that health insurance coverage escalated. And to the extent that presently we have about 14 million plus, compared to probably 11 or 12 at the national, is a testament to the fact that subnationals are doing well. Now, we cannot extrapolate best practices if we don't have a strong coordination with the center. That's NHIS. And it is important to state that our collaboration with NHIS is not from the point of competition. It took them a long time to realize that. So now that I suppose they realize that, we need to build on that. And I hope NHIS is listening, because it's important for them to know that some of the common regulatory frameworks that boost enrollments are not there. For instance, we had this ICT framework which NHIS mooted early 2020, 2021 during the COVID period. It was VSAT. That's an old technology. It wasn't sustained and it died a natural death. Now we have different pockets of ICT platforms in the various states. Assuming we have something uniform, interoperability will be enhanced. You can leave Lagos and go to Port Harcourt and still access care without having to register again. It's not happening. And there's a lot of discrepancy in the achievements of state shares. Lagos is doing well, Delta, Katsina, a few other states are doing well, pockets of excellence. But what is that compared to 36 states and FCT? So what used to happen between 2020 and 2022 was that the DG, ES of NHIS used to go on advocacy visits to the states, and I can count 6 states that pay their counterpart funding and pay the formal sector money on account of the advocacy visits. In the past 3 years, no single advocacy visit from my own perspective, joint one, has been undertaken. So that is why you have some states who till today have not started the formal sector. In an environment that is 6 years old, where some states have 3 million, some have 1 million, some don't have 50,000. So that speaks to lack of coordination. And I'm sure that the SHIAs will continue to address this, because that was the vision we had when we set this up. One more thing. When we had COVID, Dr. Guinea, remember, there was a CBN intervention fund, which somebody told us we could access. And our intention was to use it to provide a uniform ICT platform. We wrote a letter and signed and sent to CBN. But the scheme was frustrated by somebody from the regulatory body, because it was thought as being competing with them. So these are some of the things we need to understand, that when we work in synergy, we tend to achieve more. And that is why the team is very important. Together, each achieve more. So I want to call on the regulatory body to work with the SHIAs more proactively for the good of the country. Thank you very much.
Thank you very much. And I'm sure that the rapporteurs are, taking notes and will bring this on. Seriously, we cannot go far if we leave the custodians of our tradition and culture behind. And today the dynamics at that level has changed. Our traditional rulers are very alive. We have with us, I cannot call you ex-banker, because I believe once you're a banker, you're always one. So you're very germane to the conversation we are having here. So, sir, in strengthening primary health care quality through local ownership and accountability, which way forward?
Thank you, Antimoji. I believe the way forward for ownership of is through the traditional institutions. Like you said, we are the custodians of the culture, we are the custodians of tradition, and I believe in northern Nigeria, also the custodians of religion. We are the gateway to the populace. We have contact with the local level. We have a structure that cascades down to the lowest level. And I believe with our buy-in to healthcare programs, there will be a lot of improvement in the uptake of healthcare. Like, for example, even the polio program, most of the successes recorded were due to the involvement of the traditional institutions, mostly in the northern Nigeria. Of that I'm sure of, because part of it too. So we have a very critical role to play, and we need to join hands with both the private and the public sector actors on health, and I'm definitely sure we'll go far in this. Thank you very much.
Has that been an experience that you want to share with us?
Well,
has it contributed to the success of Katsina State?
Yeah, we have. Okay, the first instance, like with the community-based healthcare insurance, that's my local government, my village, was I think the first local government in, I'm not sure, but I believe in northern Nigeria, to start the community-based contributory healthcare program. We had about almost 150,000 enrollees. Yeah. At some time, we had one of the best contributory healthcare schemes in the country. But Nigeria, so many things came up. TSA came up, we had money in our account. TSA wiped out everything. So we had to start, we tried to start from the scratch. And it's still proving a bit difficult for us, but we are still doing some things in respect of community-based healthcare programs. Yes, thank you.
Thank you so much. This is a collective responsibility. You've listened to all, these experts have spoken. I would want contribution, comments. You make your comments as short as possible. And if you have any questions for anyone, yes, I recognize you, sir. Of course, Chair. At the back there, the woman, yes, in blue, I recognize you. Yes. Yes, 1, 2, 3, 4. So 4. Nobody from the other side. All right. So can we take the 5? Okay. I'll please want you to be as short and precise as possible. You might need to come to the platform here so that we can get your audio effectively. Thank you. There's a microphone there, but you can use mine.
All right, thank you so much for organizing this beautiful summit. I have 2 very quick comments. Yes. The first comment has to do with the boosting, the kind of care that healthcare facilities will give to enrollees. The truth of the matter, Auntie Moji, is that how healthcare facilities treat enrollees depend on how the insurance body treats the providers. I was a bit taken aback when Olorogun Apoveta said Delta State is paying 500 naira and 520 for private hospitals. And he said there is no state that pays more than that. Here in Ondo State, we receive 750. So, which is more than the 500. Even at that, we are still feeling that it's small. So when Olorogun, Dr. Apoveta said it is one of the highest, I was a little bit surprised. And I have friends who have practices in Delta State. I know they are complaining. So Olorogun, sir, please, we want to believe that when you get back to Delta, you will tell His Excellency to do better. And I personally believe, that there is no state insurance agency that should pay less than the 1,500 that NHIS is paying. It's like you being a classroom teacher. You go home to teach children. You have two families. One, the parents are paying you 1,500. The other, the parents are paying you 500. You will treat one better than the other. We get drugs from the same market, and we are treating people with two different tariffs. It wouldn't make sense. So if you are going to get the best from state, I think this body, the State Social Health Insurance Agency, should make it a rule that no state should pay anything less than what NHIS is paying. That's number one. Then the second comment I quickly want to make.
You have to.
1 minute, I'm
Yes.
rounding off.
No.
It has to do with transparency.
Okay.
Most facilities will have issues when it comes to claim submission, claim vetting, and payment. I want to appeal to our state health insurance agencies that every state insurance agent should have a website where the healthcare providers will post their claims. On that website, the TPAs will vet it and it will be posted there. And when the payment is made, it will also be posted on the website. So that way, the providers, the insurance agencies, and the TPAs will see it transparently. And that way we have...
Ably using the technology.
Yes.
Thank
yes,
you so
thank
much.
you.
Yes, I would like to bring on Dr. Safa. Well, he has to do his PhD now. Dr. Safana. Yes.
Thank you very much, Dr.
Yes.
Antimoji. My question goes to the traditional institutions straightforward. The fact that the SSHIAs are making effort to upscale the enrollment in the informal sector, which is about 90 to 95% of the total population of this country. What role the traditional institutions can play in, first of all, to enroll people into the scheme, and secondly, to ensure good services. Considering the fact that these healthcare facilities are within your area of jurisdiction, what role can the traditional institution play in terms of monitoring, in terms of ownership? How do you feel that ownership can make impact towards service delivery, especially having synergy with the primary healthcare agency and also the contributory healthcare agency? Thank you.
Thank you. We'll take all the questions. We'll just jot down those that concerns us. Yes, from FCT, the pump sake, right?
Thank you, veteran journalists, for the opportunity. Highly esteemed members, distinguished panelists. As an addendum to what the gentleman that just left has said, not Dr. Safana, the last man that spoke before him. If you don't blow your trumpet, nobody will know. At the level of the FCT, the honorable minister who is adjudged to be as Mr. Project is paying 1,000 capitation per head. Secondly, it may interest you to note at the last National Council of Health, that was held at Calabar between 17 to 21st of November 2025, FCT was adjudged to be among the best performing states in Nigeria. Thirdly, of recent, Moji, FCT has emerged as the top performing state in terms of malaria elimination. The Iron Lady sitting right here, Belgore, because she's shy, she's doing so much. Let me tell you, she has succeeded in enrolling. Let me give you the statistical data so that I will not mix it up. The total number of lives of enrollees, Antimoji, 245,000. University of Abuja, 3 tertiary institutions. We have University of Abuja, Federal Medical Center, and the National Hospital. She is doing so much. At the GWACS, that is Gwagwalada, for those of you that are familiar, she has enrolled over 10,000. At Garki Hospital, over 12,000. At Asokoro General Hospital, about 9,000. Kubwa, 7,000. I can go on and on. That is why Mr. President and Commander-in-Chief of the Federal Republic of Nigeria has doffed his cap for Mr. Project for doing a job well done. Let me tell you, distinguished guests, ladies and gentlemen, this unwavering commitment and support, the gentleman that made that speech, he mentioned 2 critical success factors. There is a gentleman by name Ayodele Ikotun. He's a renowned management expert. He has written a book titled Leadership. He asserted that leadership is a critical success factor in nation building. He mentioned here some of the critical takeaways. 1 is political will. At the level of the FCT, what is hindering us is only one out of all the recommendations he has elucidated. That is the act establishing the bill. That is why she's the only one left behind answering directive, which we are hoping with the support of this distinguished gathering, FCT is going to have a piloted Iron Lady, like the way we have the ES of the NHIS. She is doing us proud at that level. Please, I have a question for the gentleman that spoke yesterday at the level of the Governors Forum. He said they are communicating to the governors. I pose a question to him that we, our honorable minister, is not part of the Governors Forum. But on the strength of the Nigerian Constitution, Section 299, 1999 as amended, the FCT is considered as a part of the 36 states of the Federation. Therefore, Moji, our veteran journalist, please escalate my question to that gentleman, that what will he do to cascade what he's cascading to the governors, so that our honorable ministers, the honorable minister who is adjudged to be Mr. Project, which he has started the project today and is going to extend it to the 17th of next month. He is doing so much at the level of healthcare. Thank you, and distinguished
Thank you.
guests.
Thank you so Thank you so much. The microphone is not working. Hello? He has killed the battery. FCT went with the battery. FCT went with the battery. The battery.
Hello, hello, hello.
The battery.
Yeah.
Thank you very much for speaking so passionately. And I think that we should give the young woman here a very loud round of applause. This is Fireside. Thank you for that. Which goes to show that if you give women responsibilities in this country, we'll move faster.
Congratulations, FCT, for this wonderful achievement. Comrade, thank you for elaborating that. Thank you. I'll just be brief. My question is to any of the panelists regarding the informal sector. I know we have all been sharing statistics here, data, huge numbers. Please, I don't know if there's any state that I've had, maybe, aside from maybe Delta, who has presented there on a large cover of the informal space. And considering the challenges in covering that space, what are the practical ways that states can copy out and then transfer to their own leaders so that to achieve the same results? The informal space, building the trust in enrollees outside the formal sector is really tough. Then the second thing again is going from one state to the other. What can be done to ensure that access to care does not really stop because of maybe boundaries or anything? I think someone was mentioning something like that. If it can also be discussed. Thank you.
Thank you so much. Yes, please.
Thank you very much. I would rather say Mommy Moji. I hope you allow me to say that. I just want to talk about the part of the enforcement. You agree with me that from the presentation made, something worked for Lagos, which stands out, which is the strong political will that they enjoy. And this varies significantly across all the states. So I will, as a staff of one of the SSHIAs in the House, to see how we can also make the most of this summit by charging and also looking at the possibility of leveraging on the strength of this forum of CEOs of SSHIAs to, number one, come up with an harmonized blueprint of these enforcement instruments that Dr. Ogini took us through, so that we all focus and move in the same direction, so that we can move far. That is one. And so that this body, forum of CEOs, can actually now take up these blueprints and see how they can do this advocacy to make sure that every state achieve this. And in achieving this, this is one thing that I've deduced, is that even when we go to our various governors to say that this is what we need to do, the first thing they want to know is, as the federal government directed that we should go and do it. So even while we know that we need to use this enforcement instrument, Dr. Safana, sir, we would like that the body has a blueprint and that you use your body to push for it, even right from the federal, so that at the state level, it can be something we can refer to and say that this is what is required for us from the federal. Thank you very much.
Thank you so very much. Thank you so much. I would take the microphone round. I know, sir, representative of the traditional institution, a question came for you. And sir, also, a question also came that I would want you to speak to. But I think it's important for us to note before we forget that harmonization keeps coming up. Harmonization of the blueprint that will ensure that there's a synergy and it becomes a document that indeed this body can use when you make advocacy to the governors. Yes, sir. Do we start from? Okay. Let's start from this.
Thank you very much, Antimoji. My director, you asked what role can the traditional institution play in enrollment and ownership. On the issue of enrollment, we play a very critical role in that, because we advocate, we sensitize, and we mobilize our people to come and register under this scheme. We try to educate them and enlighten them on the benefits of these schemes that you have, and also on the benefit of all the health programs that we have. That is the role that the traditional institution plays on enrollment. On the issue of ownership, I'm sure, my DG, you know what Katsina Emirate Council and Ora Emirate Council have done on the issue of ownership. These two institutions directed all village heads, all district heads, all ward heads to take complete ownership of these facilities that we have in our domains. You are expected to go on visits, I don't know what to say, monitoring visits to ensure that what your people are getting is qualitative health care, access to quality health care. These two emirate councils have directed all the traditional leaders of their localities to take ownership of the facilities in their localities. And this has been going on for, I don't know, I can't remember the last time that, the time that this directive was given. It has been over 10 years now, and we have been doing that. We have been keeping track of what is happening at these facilities. So I believe the traditional institutions have already taken care of what my director said. Thank you.
Thank you, sir. We'll go straight to our father in the house, Dr. Kabir Mustafa. Yes.
Thank you very much, Moji, once again. I think I need to make some comments because I've seen there are concerns around the capitation that is being paid, which varies from one location to another. And then also, one consideration we have to give to that supply side is, in general, the services being rendered are not just specific to the public health facilities. We have the private sector that is also participating in the program, because the program allows for both the public as well as the private sector to operate. So for whoever is operating, he has to have a break-even level for him to provide the service. What am I trying to say? We need to, at the level of the service provider, ensure that whatever capitation is being paid to us, we break it into the respective segments of the service delivery or the care that we are giving. Part for drugs, part for consultation, part for the investigations we are doing. It is only if we do that at the end of a month, we'll be able to know, are we really breaking even or not? Now, one other factor that is key in health insurance is the numbers. I recall when the NHIS started, you had some facilities that had only one enrollee attached to that facility. And the capitation then was about 450 or 359, I can't recall, sorry, the correct figure. So that facility that has only one enrollee, unfortunately had that one enrollee visiting that facility more than once in a month. And that capitation is not enough to pay for those encounters. So it is the number that really matters. And for every facility, you have to ascertain that at the end of every month, you look at what capitation comes to you and side by side, calculate what investments you've done in that services. The more the numbers you have, the better. We saw that the encounter is just about 10%. So if you have 500 and it's only 10% of the enrollees that visit your facility, which means just about 50 will visit your facility. And for what conditions? For varied conditions. So take malaria, which is the commonest cause. We said malaria is just about 2,000 or 2,500. So if you do that, definitely at the end of the month, it's either you break even or you go under. So if you are going under as a facility, then you have to look at ways and means to do it better, especially in the private sector. But for the public sector, payments are made for the salary, payments are made for the facility, and the government is supporting the public sector. So it is easy for the public sector to take whatever is given to it. But for the private sector, they really have to look critically at what it is that it's coming to them. But as it may be, the community health insurance, I think in most of the communities, what we have are the public facilities. So that could make it easier for enrollment. But what is important is for the respective community members to identify their capacity to what they can be enrolled in, so that the contributions will come from the community itself to service whatever requirements would be for the conditions. In fact, there are times I used to think that for every specific community, they may have some specific health conditions that are peculiar to them. So cost those specific health conditions that are peculiar to that community, come up with a fee, and then they pay it. And that will make it easy for the community enrollment into the respective facilities that might be there. These are just thoughts. And this is left for the SSHIA to look at how best to it. And then one thing that is very key and important for us as we move forward, we have to be doing research and development. We have to have data. We have to work with data. Whatever we are doing, if we don't use data, there is no way we can see critically what the progress will be from it. So I believe we do that as we move forward, we'll get there.
Thank you very much.
Thank you.
Yes, I know that you are all eager to jump on some of the comments that have been made. So that will be your closing comments as you speak on. So you have the microphone. Let's hear from you.
Okay, thank you very much. My remark is one, beyond insurance, quality is very central. People will access service only when they have trust, they feel they are engaged, they are informed about the care. And I walk around yesterday. I even called my colleagues, even while we were seated, while these beautiful presentations were made. I think some of them are not really appreciative of what I listened and heard today. So my ask is, Forum of SHIA, work together with the SPSCDS very closely. As the chair of the forum, I want to assure you of the full cooperation in terms of joint planning, performance measurement, transparent reporting, and importantly, let's also be paying for quality care, not necessarily access. So much emphasis on the numbers, utilization, claim verification, but if people are dissatisfied with the care, disrespectful patient engagement, they are not likely to come back, and the expected outcome will remain negative, and this is...
Thank you. Is the microphone still alive? No. Okay. Is it working? Yeah. Is it working? The microphone must come alive. Thank you. Borno, I'd like to come to you quickly. I'll go back to Borno so that, yes. Yes, and I just want you to address the issue of informal sector, incorporating the informal sector. How are you coping with this? And this will be your, this will be your final statement. What exactly is happening, or what should be put in place that can engage also the informal sector?
The informal sector? Or
yes,
the
informal sector.
Okay, the informal sector. Actually, for the informal sector, I think one important thing is that, for me, is one of the easiest sectors to engage. Why? Because over 90% of the population are actually from for the informal sector. But the puzzle is actually the trust. What I believe is that if people are sure that you are going to offer quality service to them, you will see them trooping in. But so far as there is this issue of lack of quality service from the supply side, that enough is something that will actually drive them away from patronizing. So if there is anything that we can do to attract from informal sector, is to ensure that our services are of good quality, because sometimes they say good products sells itself. So if you have a good product, you don't need to suffer marketing nook and crannies to get people into the pool. Thank you.
Thank you very much. Welcome, sir. Yes. Are you done? No, I think we should take the microphone back to him, to the traditional ruler. His final word, yes.
Want to say something?
Thank you, Antimoji. My final word will be, it's a commitment from the traditional institutions to my DG or to everybody that the traditional institution is always ready, and we are ever ready and we will partner with everybody from the health sector to improve the quality of healthcare provided to our people and to ensure universal health coverage for everybody in Katsina State. Thank you very much, ma'am.
Thank you. Okay. Sir, you still want to give the final word? Dr. Kulu? You still want the final word? Yes, Dr. He has given his.
Yeah, thank you very much to all the participants and then to the SSHIAs. I wish you progress in all the encounters that come ahead, and I believe putting heads together and kind of peer review, just like has been done here today, will go a long way in ensuring the success of the social health insurance in the country. Thank you.
Thank you very much. Just to also let us know that as a forum, we're already working on portability of the health insurance schemes. What do I mean by this? We're working on a situation whereby an enrollee in a particular state goes out of state and is able to access services in another state, through a portability system that has already been deployed and is being piloted in 9 states already. So hopefully by the next summit, by the grace of God, we'll be able to showcase what we have piloted and scale it up to the remaining states across the country. And also to add on a final note that health insurance is a game of numbers. So if NHIA, for example, is paying 1,450 and the shares are paying varying rates of capitation, that is because of the varying pools of funds that we have at the respective states. So harmonization, like my mommy has said here, would help us a long way to ensure, enforcement, mandatoriness, and equity fund support from various state governments to cushion the numbers, and that would help us to be able to measure up with the level of capitation that is being desired by the healthcare providers. So thank you very much, and I want to appreciate on a final note our FCT team here present. Please clap for yourselves. Yes, and my permanent secretary here present. Thank you very much. Thank you.
Thank you very much for your patience. Insurance is a game of numbers, and fragmentation of the pool is counterproductive. Part of what we have learned as pioneer SHIA leaders is that we need to aggregate. Since we cannot do that immediately, some of us have looked at the informal sector as a starting point to aggregate. As I speak with you, we've had, as a TPA, we've had 3 consultations with the national bodies of artisans and some other groups in Abuja over the past 2 months. There is still another summit that is coming at the end of this month in Abuja with artisan groups. They were here yesterday, but they left. They couldn't come today. And they were properly invited and they participated. So what we think is that when we start with them as a database and as a pooled mechanism throughout the country, they'll be in one database so that they can access care from one town to the other. It will serve as a model for the formal sector, which in any case is much smaller. Because the informal sector, MBS says they contribute 65% to the GDP, and they are made up of 92.3% of the population. So that's a good place to start, and we are doing that currently. Thank you very much.
Thank you very much. A round of applause to our panelists. We've spoken to improved quality service. We've also spoken to more interactive session with the regulator. We've also asked for commitment in terms of ensuring that services at that level, particularly at the lower level, is of quality that can attract people, because we know that it's all about numbers. And of course, commitment to the primary health care, and very, very important, peer group interactive session that will ensure that best practices are not just spoken to on paper, but also disseminated across board. And of course, the use of technology going forward. Thank you. I hope this has been productive, and thank you very much to everyone here. Our session is over. Thank you.
Please let's put our hands together for the panelists, the moderator. Let them have group photograph,
We'll
please.
have group photograph.
Group photograph. Group photograph. Thank you very much. The moderator and the panelists, thank you so very much. Wait for the chairman, I beg.
It's becoming larger and larger. It's becoming larger and larger every day. What do you the finalists first, take it two. The finalists first and the others. Thank you very much. Thank you very much. We appreciate you. It has been very insightful program today. Thank you very much. Thank you very much. Now we want to take the last panel discussion, and with the theme, Financing the Future, Domestic Resource Mobilization for Sustainable Health Insurance. And the moderator of this session is no other person than the Executive Secretary from River State, Dr. Betty Agala. Please put your hands together for her as she makes her way to the podium as moderator for this session. Thank you.
Thank you, thank you, thank you. Good afternoon, everyone. Please, can we just rise? Just stand up and shake your body somehow. Do something. We are adults. We shouldn't be seated for so long at once. Please, just make sure you're moving yourself around. Yes. If not that we are in this high-level meeting, we would have spelled coconut, but it's okay. You can move your legs, move your arms, but if you have done so, then you may sit. So, we're going to be talking about domestic resource mobilization for sustainable health insurance. You know, we've done a number of innovations. Most of these have been piloted for maybe a year, but we don't know what happens the second year. Who pays? How do our numbers stay up? So to have this conversation with me this evening and on the panel, let's welcome our representative from World Bank. I think she's still around. She was on the panel yesterday. Please, if you are here, join me on the stage. Secretary of the Basic Healthcare Provision Fund Ministerial Oversight Committee. You were here yesterday. Dr. Zoma, I can't see you. Where are you? Okay. Also to be on this panel is the Executive Secretary of Oyo State Health Insurance Agency, the veteran himself, Dr. Shola Akonde. Is he here? Where are my panelists? Where are my panelists? Somebody bring back my panelists. What happened to Shola? Afolabi, where is your neighbor? He was sitting there. Where is he? All right. We also have to join us here, the representative from Chai. Yerima is in the house. Please come and join the conversation. And to put the icing would be my capacity chairman, the convener of this very, very successful summit, the DG Katsina State's Contributory Health Management Agency, Malam, Mr. Mohammed Safana, We are not clapping for my chairman. How? Please clap for my chairman. Where is Dr. Shola? Please, once he comes in, he would join us on stage. Okay, so where do we start from? So like I said in my preamble, we had quite a number of questions in the last panel talking about quality of care, but we know that all of these work together. So it's not just about numbers, it's about quality that help us to sustain, and it's about financing. So I want to start with the World Bank. You've had experiences with over 20 low and medium income. NGF. Oh yes, where's that young man? So it means I'll need another seat. NGF, please. NGF Secretariat Representative. Shola has to be on this panel. There's a oh, great. All right. So, World Bank. I was saying that you have been involved in financing several low and middle income countries across the globe. And you are also supporting Nigeria and funding us. How can states assess funding from the World Bank? What is that one thing that we are doing right or doing wrong that limits us from assessing funds from the World Bank?
Okay, thank you, Ma. As we've rightly said yesterday, that to access fund, quite often the readiness is always important of each state to access fund. Prior the World Bank suggesting any form of investment promotion to states, there are always gaps that must have been identified. And whilst the gaps are to be addressed, the states also need to be ready. And that is where the space of expression of interest often come in. And beyond the expression of interest, there's also the condition always put in place for states to have the counterpart funding on the side. And this is mainly for sustainability. So as we drive towards the universal health coverage dream, the bank does not only come to support, but also leave the states at the level of being able to continue from wherever the bank support stops. So counterpart funding is very essential. So quite often states that might not get the support have either not expressed interest or have not shown readiness to take it up from where the support of the bank stops. Thank you, ma'am.
Thank you very much. We'll pass this on to the NGF rep. We've talked about expressing interest. We've talked about counterpart funding. We've talked about political will. A number of things that were said here are hinged on the subnational chief accounting officer, who is the governor. And so you are from the NGF Secretariat. What do we need to do? I know we talked about scorecards yesterday, but you've been showing scorecards, and we are still having the gaps that we're having. So what's that one thing that you would do, or you think that SHIAs should do, to ensure that we get all of our governors to buy in to these criteria, so to speak, or policies from the national? We even talked about mandatory health insurance. Now we've talked about expressing interest. We've talked about counterpart funding, because we're looking at sustainability. I recall in my state, was it for a malaria program, and the governors were to bring an amount, whether 100 million or something like that, just to show that commitment. What do we need to do when we leave here? And how does the Secretariat support us to ensure especially in this season of elections and all of that. How can we get it right and get all of our states running with the policies that are on ground? Thank you.
All right, then. Thank you. Good afternoon, everyone. Once again, it's great to be on a panel session. I don't know, moderator, please, if you would indulge me. I think I would like to respond to FCT first before I give you a response, if you don't mind, quite quickly.
With my time?
What?
With my time? Go ahead, don't mind
Thank
me.
you. So FCT asked earlier, what do we do in terms of trying to engage the minister and the mandate secretary as well. So we also, in the secretariat, we've taken cognizance of, how tricky it is, seeing as, the FCT minister is a minister and not a governor, and we are, NGF, Governors Forum. But in terms of the advocacy materials that we develop, we also make sure that we develop with the FCT as well. So all our state health profiles, all our SSHIA scorecards, they are all developed with FCT as well. So you could also access FCT data. Then through the Health Commissioners Forum, we also make sure we engage with the mandate secretary a lot of times. We have a lot of back and forth. So we're friends with the mandate secretary as well. In terms of the minister level, maybe that's something a bit above beyond my pay grade to answer, but I will make sure it's something we discuss when we get back to the secretariat. So that's just the answer to FCT. And now back to the normal conversation. I think one major thing that hasn't really been stated since this summit started is there's been a lot of PFM reforms that have happened in the state since 2021, and NGF has been at the forefront of that in terms of trying to improve how states, do their budget, prepare their budgets, and how they also release these documents. Since 2021 till now, I can tell you for a fact that we've gotten to a point where wherever you are in the world now, maybe it's by quarter or be it end of year, from anywhere you can now see how much a state is budgeting and how much that state spent in that same year. But people don't take into cognizance the different segments that go into that same document. That same document is broken down into administrative classification, economic classification. We also have something that is very important called the program classification, which actually just started 2 years ago, or a year ago actually, where states now report how they are spending money on health. But it's not just the generic, general health spending. It's now broken down into various specific health important areas. We have things that cover HRH, we have things that cover health governance, we have things that cover health infrastructure, we have things that cover health security. One major thing we also have is how much the government, any state government, is spending in terms of universal health coverage. So that segment shows how much is being spent there. So I would now charge the SSHIAs, we should use this information that we now have for advocacy. There's a difference between accountability and transparency. In terms of, getting that data, it's now a bit transparent where we can, but now the bit of accountability where we're, trying to hold governors accountable to say, okay, sir, we've seen what you spent. We don't think it's enough. Your budget implementation for UHC especially is not enough. So that's one thing I think I'll charge us. We should go into our state budget documents, budget implementation reports, understand how the National Chart of Accounts segment works, and the segment that speaks to universal health coverage, we should make sure we really understand it and really check if states are, spending money against that line or not. From our desk review, the last 2 years, we realized that most of where money is being spent, especially for health across states, is health governance and also health infrastructure. But major things that move the lever, service delivery, things like essential package of health services, they don't necessarily get enough spending. So on one step, I'm praising my principles. Since 2021 to 2026, it's been a far cry. We've made, more, there's now transparent data. Anywhere you are in the world, you can get access to those budget documents. You don't have to know anybody in the budget office. You don't have to know any accountant general of any state. You can get access to that document. You can get access to that data. But now, the level of accountability now to ensure that we're holding our principals accountable to say, okay, sir, if you budgeted $1 million for, universal health coverage, we need to ensure that at least by Q4, you've released at least 75% or over 67% of how much you budgeted for that level. So I would really charge all of us to, go and understudy this document and how we can use it for advocacy. Thank you.
Thank you very much, NGF. We're looking at performance management. Is not just about more money for health. We're now talking about more health for the money that we already have. and NGF is doing their bit. They have passed the baton, or at least some of it, to the SHIAs. So I want to ask Chai. Chai, you are supporting a number of states, capacity, organizational capacity assessment, and then you find those gaps, you try to help. But is there something states can do differently to be able, because we're talking about sustainability, and so it's beyond just even assessing any fund. It's about sustaining our efforts. It's about ensuring that those that are enrolled, for instance, continue to access quality care. And what that means is that the providers should be happy, right? The beneficiaries should be happy. And then more money comes into the system because it's a game of numbers. So what more can you do? Ditto other technical, people that provide technical assistance for states, for us to be more efficient, improve on our spending, actually determine our premiums and all of that. I know you're working with a few states, but how can the health partners group, so to say, the health development partners group, support every state? Not that everybody is in one state or one zone. How can we actually have every state get the support they need to have a good foundation to plan with sustainability in mind?
No, thank you, Dr. Verti, and good afternoon again, everyone. This is quite a loaded question, but I will try to do my best to respond to it. So maybe first of all, starting with what exactly should states do to sustain health insurance coverage, right? And I will take a case study of the equity schemes, like the Basic Healthcare Provision Fund, like the state-specific equity funds. I think there are, anywhere in the world, there are 3 ways to fund healthcare for the poor. Just 3 ways. One is to get more allocation from existing budget, which is what the colleague from NGF has emphasized. How do you do more advocacy? How do you get the government to release more for you from an existing pie of resources? Which I would argue that is really very tough. For a very long time, I haven't been so enthusiastic in engaging in a lot of advocacy. And I will tell you why when I talk about the 2 other ways of generating revenue. The reason is very simple. Government is battling with a lot of challenges, right? Like if you simply look at debt to GDP ratio, you really come to realize that government it might be generating more revenue, but it has a lot of debt servicing to do. So there isn't so much money from government to allocate more, in my opinion, and we can discuss more if you contest it. The second way to generate revenue is to think outside of existing government budget through something you could call off-budget ways, innovative ways. Do specific earmark taxation for health, have innovative means of financing healthcare. Like there are many models of innovative financing which I can touch on if time permits. But number 3, which I would argue, and tying it to the second part of your question, for me I think is the most critical. Number 3 is improve efficiency in spending the available budget. And if you just take the Basic Healthcare Provision Fund as a case study, I think many people may not be aware, but between 2019 and 2025, about $532 million were disbursed through Basic Healthcare Provision Fund. That's more than $500 million that has been disbursed within the Nigerian healthcare system, right? But if you look at what that money has purchased, a lot of progress has been made, but some people might argue that there is room for improving more efficiency in how those funds are being spent. So if you ask me the second question, what should states do better? I would tell them make basic healthcare provision fund work first. Improve efficiency with which primary healthcare facilities spend basic healthcare provision fund and convert it into service availability. That is on the one hand. On the second hand, in terms of what development partners should do to support states, you've been mentioned about how can the development partners have a general united front in supporting states. My take would be that the states have to take the leadership to fund the health system and set the what do you call it, strategic direction, and be the ones to proactively involve technical partners to support them to actualize objectives / goals that they have set for themselves, right? And I guess a way to do that quickly is that, specifically on health financing, is not to think of a one-side. We have that tendency of thinking that because we work in 3 states, we just take one model from Kano and take it to Kaduna, or take one model from Ondo and take it to Ekiti, just because of geographic proximity, right? But that won't work. Most of these innovations, most of these strategies for improving both financing and service delivery has to be context specific. And development partners should only work and support states to implement interventions and goals that they have set for themselves. Thank you.
Thank you very much. You've tried to tell us the sources of our funding from budgeting, and not just budgeting or allocations, also efficiency gains. Don't smile, don't smile too much. Don't worry, you're not on the hot seat. But we're talking about planning, we're talking about budgeting, forecasting, and all that. And so you have a set of enrollees, you have funds earmarked for capitation, operational costs, and all that. But those funds are not coming as at when due. We have the other bit about the states not committing to the formal sector, which would have been another source. But for those states that for now are trying to harness basic healthcare provision fund, what will be your counsel to us? What do we need to do for you to meet the needs of the MOC, for instance, and the objective of why the basic healthcare provision fund was set up, vis-a-vis catalyzing the universal health coverage? What would you want us to do? Because we are here in this summit trying to get some take-homes, takeaways that by Monday morning we should hit the ground running with. What would be your advice to us?
What do you want? Do you want the good part or the bad part? How hard do you want
Start
it?
with the bad. It's fine. We can take it.
Okay. So first of all, it's good that this conversation is happening. Before I forget, I think that this conversation, whoever is putting your communique together for this discussion, needs to, perhaps the leadership would need to thoroughly look at the communique, and I think that there are a lot of actors from the NGF, from the Federal Ministry of Health that will be interested in seeing what goes into your communique, so that it becomes actionable. A lot of people have put out a call for some sort of blueprint, she called it. But look, let me take a step back and remind you of some of the things I said yesterday when I spoke. I reminded us that insurance is something that is fairly new in Nigeria. Social health insurance, as we like to call what we're doing in the States, that should be contributory, but not always is something borrowed from Eastern Europe. A very formalized structure where most people have a job. Those days working in factories, so it was easy to deduct monies from people. So that's not what we have here. What we have here is a huge informal structure, as you know. That creates problem number one for all of us, right? Your conversation is around mobilizing domestic resources. You have Chai here and you have World Bank here. Those are not domestic sources. The source for domestic resources is what the SSHIAs are doing in terms of collecting premiums from people. That is domestic, that is indigenous, that belongs to us. The other one is what BHCPF tries to do, which is getting monies from, appropriating resources from government, something really very bold. I'm happy that we're all talking about BHCPF as catalysts. As catalyst. The idea is for it to be the catalyst. Now, that thing that BHCPF has done, you heard in the news that Champions for Health went back again to try to play around with the word. If you remember the wording of the law, it says at least 1%, at least, he didn't say at most. He said at least 1% of the consolidated revenue fund. Why? So there are two things. We had stayed with 1%, never gone beyond 1%. That was not the intention. So we went back again to say, okay, at least 2%. And you have heard that the both houses of assembly have passed it, waiting for presidential assent. Now, it is consolidated revenue fund, not federation account that has states contributing. So it is a smaller pot. Therefore, the action and the game-changing strategy here, again, has to be the states. The states have to replicate what the federal government has done. The president, the coordinating minister of health, and with the actors at the national level have made these things to happen. But the contribution from states can never be compared to this single pot of the federal government. So imagine if all the states also put down, even if it's 1% of what they receive across the 36 states and the Federal Capital Territory. That changes the equation. Why is this important? You see, social health insurance, we can only maybe get 30% of the population across all the states. That informal sector, I'll take you to Indonesia and Philippines. Indonesia has a population of nearly 300 million people, 280 something million. Philippines has a population of a little over nearly 200 million, or 100 and something million. Both of them have achieved coverage of, he was there when Indonesia announced that they've achieved universal health coverage. That means everybody in Indonesia is enrolled in insurance. Everybody. So we're talking about numbers in 90%, 90 something percent. How did they do it? Because they also have a huge informal sector. There is a piece of work that was done by the World Bank and WHO during the UHC coverage hub, and it showed that, look, you cannot, anyhow you want to discuss informal sector, community-based health insurance schemes, any form you want to do it, there has to be that government paying for the poor. There is no other way in which you're going to be able to do it. So that means that what the federal government is doing with BHCPF, states, if they can replicate it, then we are getting to that point. Now, what I'm saying in essence is that this funding, BHCPF, remember, was supposed to be for people who we thought could not pay. When insurance started, the idea is that if you have a job, you'll be able to pay. So we're struggling with the problem of collecting premiums from people who have jobs. We have very well-to-do individuals in the states, and we can't collect. We're talking about capitation of 1,000, 1,500 or 500. We're not even able to collect that from the organized private sector. So, but now we're all looking forward to disbursements for those people whom we all thought could. So all of us sitting down here, if you check very well now, we might not be paying premiums. If you check very well in our insurance schemes, we're all seated, and those who don't have jobs are the ones who are sustaining this. All those monies that states have in their coffers, a lot of them, a significant proportion, is from that. So we need to move away from that. And I challenge all the chief executives of the SHIAs who are here, you are the purchasers. I was happy that you brought in MP, the state's primary healthcare development agency, the owners of the facilities, the providers of the services. There has to be a point where you begin to foster collaboration. Perhaps this conversation would be good, would be rich, if at the next one you're having the mix of both together, because they have to make the facilities ready for you to be able to purchase service.
Absolutely.
On disbursement that you asked me, let me, because I didn't answer your question first, I wanted to knock you first, then I can answer your question. So for us in the MOC, right, what we're trying to do is to, the BACPF is arguably Nigeria's most sustainable, predictable source of domestic resources. What we're doing is, as long as federal government releases quarterly to us, we have to, the Honorable Community Minister ensures, in fact, that is one of his performance metrics, disbursements. Now, what do? MOC convenes quarterly, approvals are given for release to happen. But what is the rate limiting step? As at last week, I had a meeting with the gateways, MPHCD and NHIA. We're still waiting for, okay, they told me that they had just received the final retirements from states. This is a problem. So states, if you don't send in retirements on time, we cannot disburse. In fact, there is a gateway that has just spoken to us. There is a huge backlog of retirements. You know, even if we push these monies, the BHCPF, there's an oversight from National Assembly directly on the BHCPF. So if you want your monies to come regularly,
we should retire
and on time, just retire what we are giving you the quarter before, and you can be sure that once we have the approval of the minister, which
let's clap for MOC. Let's clap for him. He has pushed it back to us. So we're talking about retirement. We're talking about state level actions. You know, he said something around what the subnational is doing, and I tell you that most of our laws are replicating what's happening at the national. So most states have at least 1% consolidated revenue funds. My state has 2%, and so that provides for equity for more than double of the number that that the Basic Healthcare Provision Fund is bringing. So my chairman, sir, you are here. You are representing 36 plus 1 CEOs. A lot has been put on the CEOs. First of all, I want you to tell us a number of, and I think we did that with innovations, but let's look at innovations around domestic resource mobilization, how states are coping with funding, considering, you know, we can see the big elephants in the room. We all know our context. But what are your colleagues doing in line with domestic resource mobilization? Because we're already doing that, a lot of that. Just give us 1, 2, 3 ways that maybe a few other states can take on, and then I will ask you one final question.
Thank you very much, my secretary. Good afternoon, ladies and gentlemen. I'm really happy that by my right side I have the Basic Healthcare Provision Fund, and by the left side I have the Nigerian Governors Forum. So that makes the discussion balanced. Exactly. And we have the donors around, and that makes the discussion much wider than what it is now. First of all, the state agencies from inception, when we started this forum, we were able to develop different strategies in different states, you know, to see how we can to source resources locally, domestic resource mobilization through adoption model from Anambra, and we have so many other models from other states, and also people target philanthropists in some states, you know, to intimidate them to come and enroll for some vulnerable populations around. Some go straight to the government, you know, requesting for a special intervention to a particular situation. Specifically in the northeastern part of the country, we have state governments that have contributed immensely to make sure that those people that were displaced have been taken good care of, because we believe healthcare can never be free. It's either you pay for yourself or someone pays for you. And that brings about the discussion I want to make here. At least this is the background, as you have rightly requested. The fact that we have the Basic Healthcare Provision Fund and we have seen its impact over the years. It started from the scratch, as we have all witnessed from the previous presentations, to what it is today. We have more than 3 million Nigerians enrolled under the Basic Healthcare Provision Fund. Then we have the Nigerian Governors Forum that made efforts to ensure states have full state insurance agencies that drive the process of implementation of the Basic Healthcare Provision Fund. At this very time, when you look at the theme of our summit, economic realities, what is happening in the world now? We can see many countries are into recession now. How do we source funds? The international donor organizations, the funding coming from international community are not forthcoming now. So it's a real signal for us to see how we can employ desperate measures, to improve that. And more importantly, as you rightly mentioned earlier, the state governments, respective state governments have really invested heavily in healthcare. You see health investment in infrastructure, more services coming in, especially at this very contemporary time that we have non-communicable diseases that are coming up. So many states have really invested to see that they bring these things down. So at state level, from the perspective of the shares, we are looking at another way to have a sustainable funding. One of the ways is what Kano State have done. Kano State established what we call the Kano State Health Trust Fund. And that is in line with what we have just mentioned now, that states should be able to appropriate money so that we can expand health insurance. So if you have an agency backed by law and having a particular source which is directly from the federal government, from the revenue, consolidated revenue coming from the state. I think this summit, if we can be able to put these things at this very moment, this idea, if we can, harness this idea, I think it will go a long way in solving our problems, in ensuring domestic resource mobilization to stay, considering the fact that we have autonomy by the local governments. So we have the ALGON, we have the NGF, BSCDF is a testimony that funding is coming to expand health insurance. So if we are able to establish a framework that guarantees funding every month or every year or for a particular period, like the state health trust funds across the nation, I think that will go a long way in guaranteeing sustainable health financing. And the target of universal health coverage by 2030, I think, will definitely be achieved. Thank you.
Thank you very much. That's very optimistic. Let's clap for my chairman and clap for all the shares. There's a lot of work going on. Many states are actually mobilizing resources within the ambit of their context. So I want to just briefly take us back. This is the last panel. So I want us to go back to the theme of the conference. And it says, economic realities and the UHC dream. Mobilizing states. These states is resources, domestic resources. Mobilizing domestic resources for a scalable health insurance. Before I have my panelists say their last points on this, because they will speak to this, I don't know whether we have comments, questions, because this is the last session and everything that we have done that will be part of the communique will be said here and taken by the team. So we have one. We have a hand this way. Oh, someone is already here. We have a second hand. Okay, sir. So we just have three persons. Okay. And four. That will be the last. So let's hear your perspective, whether you want to suggest to states different ways that they can mobilize resources beyond what has been said, or you want to speak to the economic realities and the UHC dream. Is a 2030 target. I don't know where we are on target 3.8. We are still very far. But let's have your comments and your questions. We already have number one here. Right, sir, please.
Good evening, everybody. I think we have had a long day. I wouldn't talk too much. They have spoken a lot, but I think we have forgotten we are looking at domestic resource mobilization, and it has to be innovative, it has to be scalable, and it has to be homegrown. So I'm not looking at any development partner who will come give technical, or there is donor fatigue already, we know that. We're not looking at the governments themselves because they don't have enough. Everything governments are doing are tax-based and there isn't enough. We have seen so many ways, and these people that we are trying to cover, 80% of the population, you know what they are going through. Even those of us who have guaranteed source of income, we are complaining. And this is a global problem. For me, I have been crying for the last 17 years of a homegrown method or source of mobilizing resources in this country. It took me up to the Executive Council of President Johnson and made a presentation, and they said it is doable. Even during Buhari, I gave a paper. I went personally to the government house or the villa and deposit my input. They say it's doable, but it never saw the light of the day. And I think it is doable. Today in Nigeria, we have over 200 million active phone lines, and we're busy talking. Everybody is talking, and we don't even feel it. When your airtime is finished, you are sort of jittery. You don't know what to do. Or if you lose your line, you are so jittery, you want to talk. And that time what I said is, please, let us look at giving 1 kobo per second for 10 minutes every day. That is 6 naira. Just 6 naira a day. And if we have 200 million lines, 6 naira a day will give me 1.2 billion naira. In a month it will give me 36 billion naira. In a year it will give me 432 billion naira. Come on, can't we afford 6 naira a day from our phone lines? This is homegrown, sustainable, scalable, equitable, universal contribution. You cannot get universal health coverage unless there is a universal contribution. And this is universal contribution. It is easy to collect. It's just to talk to the providers that they will reserve 1 kobo per second. And it's centrally collected, so it's easy to collect it. When I started, we had only 80 million lines in this country. Now we have over 200 million. If we had started, we would have forgotten about it, and you wouldn't feel that 6 naira has been taken out from your pocket. Thank you very much.
Thank you so much, sir. That's innovative financing. Number 2, okay, please. Go ahead. There was a hand somewhere, number 4. Go ahead, please.
Good afternoon, everyone.
I want to especially thank the chairman of the forum for such an awesome summit, and by privilege, having my executive secretary to be the ES to be the secretary of this great forum, Dr. Veti Agala, and she has been doing a great work. Thank you, ES. Now, for the discussion, having an homegrown means to raise fund for insurance. A little away from that, Chairman, sir, I was expecting to see or hear a discussion on interoperability between the states, because I know health insurance will not be sustainable among the states until there is that handshake between one state and the other. If I am insured in Rivers State and I travel down to Ondo State and I'm sick, can I be treated in Ondo State without me having to do a lot? And this is what the private health insurance are enjoying, that a private health insurance company anywhere in the world. So I was actually expecting to see a discussion on that, so that this health insurance can be sustainable at every point. Number two, as part of sustainability, I want to suggest that we can make, this is a political season, we can approach political parties in our various states to make it, you want to contest as a House of Assembly member, how many lives have you brought in? It should be part of their clearance. It should be part of their clearance. In River State, it is not done so, but it is working. A typical example is Senator Ipalibo Hari. Senator Ipalibo Hari single-handedly ensured hundreds of lives into River State Health Insurance Program. And by that, so I think it can be scaled, where politicians will now begin to ask them, you want to occupy this office, how many lives have you brought on board? Thank you very much.
Thank you very much, Mark Moses. On your first question, I can easily answer that, because the last panel, Dr. Belgore said something about interoperability and what we are doing as a forum. I think we are piloting, and I want to believe that by the next summit, that will be a done deal. So the second issue will be handled by the panel. Please go ahead, sir.
Well, thank you very much, and good afternoon. Well, I want to comment on the possibility, even though some people are advocating that, you know, all bank funds are not domestic, but these are loans that will be repaid by the taxpayers and by Nigerians. So equally, it is a domestic fund, apart from the grants and what have you. So I'm from NASCO, and I'm aware that the federal government is injecting over 1,125 billion naira in cash transfer to 50 million households in Nigeria. And we are going beyond income poverty. We are looking at multidimensional poverty. And this how make savings, and from the savings, some of them were able to draw some funding for livelihoods among themselves, particularly the women, because the cash transfer prioritized women as the caregivers. because the funds goes to the women directly. So if we are deliberate in ensuring that in our advocacy and sensitization, in what the government is disbursing to the households, we put in place a sensitization and advocacy just like what we did for the savings, the households will key in and pay premium from what they are getting, from the 75,000 naira they are getting from the federal government. And what will make them sustain this premium payment is the quality of services they will get from the initial start when they made the contribution by themselves, and then they are sure we provided the services, adequate services that will convince them. And with their savings and their livelihood, they can now pay by themselves. But the issue is the trust. They can start it with the cash transfer fund, but if they didn't get the services that they are expecting, they will not key in to pay the next premium. Then the second thing, I really appreciate the adoption 3 model, where individuals pay premium for the less privileged. This is also another window. Each one of us here is earning a salary. I understand it's not enough, but quite all right, there are sacrifices we can make to even pay a premium of 12,000 naira to a household in your village. And this household can just be picked from the social register. Because yesterday I talked about the social register, where we identify and give visibility to the households in Nigeria. And these households, quite all right, I know some of you have skepticism in it, but we are now fortifying the identifiers with NIN and then with Joe coordinates. So it's verifiable. And then lastly, I want to talk about the state equity. If we are serious, the governors forum are here. We should make that equity a first line charge, not a budgetary allocation. Thank you.
Thank you. Can we give him a round of applause? The last question.
Thank you so much. In fact, the last 2 speakers have spoken my mind about the adoption model. I just want to give you an experience we had in Gombe State. At the beginning of the scheme in Gombe State, we realized that for us to scale up services, we need to adopt the adoption model specifically on politicians. But I can tell you that it's not working up to now. At the time, we sponsored the entire legislature in Gombe State to Abuja. We sponsored their trip. We brought experts. We lectured them. We give them all the things that need to be done on why they should adopt and pay for people in their constituents. I can tell you that up to now, no one of them has done that. Our board, governing board, went around all the 11 local government in Gombe State, preaching the adoption model to local government chairmen. They have made all sorts of promises. Not one of them has been fulfilled up to now. So my question is maybe the chairman of the forum, have you considered, is there any modality that you think the state healthcare agency should adopt in order to implement this adoption model especially for politicians? Because various speakers here have said that health insurance is a game of numbers. For us to scale up services, we need to have more numbers. And a politician, one person can come and enroll maybe 1,000 people. What are the modalities that we can use to get these people adopt the adoption model, so to say? Thank you so much.
Thank you very much. Let's give him a round of applause. So we will take an intervention from each of the panelists. We've heard all the questions. Oh, you have a question. All right.
I'm sorry about this, but I need to, I need to let us know what has happened so far as the telecommunication tax is concerned. I was quite happy when, Dr. Dugu talked about the telecommunication tax. In the twilight of Buhari's administration, the authentic Professor Sambo, we were working together towards ensuring that we had the 1 kobo per second, a telecommunication tax. And it had gotten the final stage. But within the system, there were, some negative inputs from the Federal Inland Revenue Service and from some other powerful units who felt that Nigeria cannot fund their own health system. And in fact, a minister of health, we met outside the country and we were discussing. We just met at the airport lounge and we're discussing. And he said, I've always told them that Nigeria cannot fund its own health sector. And I said, no, I disagree. If only we did this 1 kobo per second, tax on communication, we are going to have enough money to do a lot of things. Aside from that, I'm a member of the Sugar Sweetened Beverages Tax Coalition in Nigeria. I advocate for the increase of sugar sweetened beverages tax. Initially, thought was not really possible, but in 2012, we got the tax to be 10 naira per liter on every sugar sweetened beverage tax in this country. Now, I am one of the people advocating for the earmarking of that tax for the health sector, for public health intervention. Now, recently, in December, I was at the National Assembly, and I pushed together with other members of the coalition, and we're pushing for an increase from 10 naira per liter to 15 naira per liter of sugar sweetened beverage tax, and earmarking it for health sector. So if we have the telecommunication tax, we have the SSB tax, and we bring them together, Nigeria will be able to fund its own public health interventions.
Absolutely.
Aside from that, now if at the national level, it is not going to be easy to do, can state governments here begin to think about how we can work together with our legislators, how we can work together with our